right, well, I think we will get started. Thank you so much for joining us for our April Pepper Rounds. We are delighted to have Dr. Leanna Ross here with us today. Dr. Ross is an assistant professor in the Division of Cardiology, Department of Medicine, and member of the Duke Molecular Physiology Institute at the Duke University School of Medicine. Leanna received her master's and doctoral degrees in exercise science from the University of South Carolina and completed a postdoctoral fellowship at the Duke Molecular Physiology Institute. With funding from the American Heart Association, National Institute of Health, and the Duke Pepper Older Americans Independence Center, Leanna's research focuses on understanding the dose-response effects of exercise interventions at the group level, the heterogeneity of exercise training responses at the individual level, and the legacy effects of exercise interventions on health outcomes from 5 to 15 years following intervention. The goal of her research is to develop an integrative molecular-physiologic-bioinformatic approach to promote precision exercise medicine and optimize health benefits. So with that, I will let you take it away, Dr. Ross.
Thank you so much. Thank you everybody for joining. I've really been looking forward to this since I received the invitation. So I'm going to jump right in. So as Dr. Bradley just mentioned, my research kind of falls in these three broad areas here of exercise dose response, individual variability of exercise response, and the potential sustained health benefits of previous exercise intervention. And so today I'm going to walk you through kind of a story of how I've got to the current work that I'm doing now as part of my Pepper research education component career development award that I feel extremely fortunate to have and now be a part of the Pepper Centers. So to kick things off, I will go right into describing the dose response effects of exercise. And the basis for my talk today is going to be built on the STRIDE studies. So STRIDE stands for the Studies of a Targeted Risk Reduction Intervention Through Defined Exercise. These studies, there were three of them. They were led by my mentor here at Duke, Dr. William Krause. And these were three NIH-funded randomized exercise clinical trials. And all three of these studies enrolled essentially middle-aged adults on average. They all were sedentary at baseline and had either overweight or obesity. And in the first two STRIDE studies, these participants were recruited basically to have metabolic syndrome. The inclusion criteria was focused on mild to moderate dyslipidemia, while the third STRIDE study, STRIDE prediabetes, or STRIDE PD as you'll see it sometimes, that study intentionally recruited participants that were considered to have prediabetes at baseline. The first STRIDE study was essentially the seminal dose response trial in our field of exercise science, where it compared the effects of different amounts and intensities of aerobic exercise on cardiometabolic health outcomes. The second study was called STRIDE ATRT, and that study was one that was designed to look at what are the effects of aerobic exercise versus resistance exercise versus the combination of the two. And then finally in STRIDE PD, that study was designed to look at, of the gold standard treatment for prediabetes being essentially the lifestyle arm of the diabetes prevention program, where we have aerobic exercise and also diet-induced 7% body weight loss. Of that exercise plus diet effect, how much of that can you achieve with just aerobic exercise prescriptions alone? So I'm going to walk through the first STRIDE study here in a little bit more detail. So in STRIDE 1, participants were randomized to one of 6 groups. There was an inactive control group where participants were asked to maintain their current sedentary lifestyle for a period of 6 months. Or participants were randomized to one of 3 exercise groups. These exercise training interventions lasted on average 8 to 9 months. We had a low amount of moderate intensity exercise group. We had a low amount of vigorous intensity exercise group and a high amount of vigorous exercise group. And so the eloquent design of STRIDE 1 allowed us to, as I mentioned, look at the specific effects of aerobic intensity and the amount of aerobic exercise. So if you look at the arrows here pointing to the 2 groups in the middle, here, both of these groups did the same amount of exercise, which we called a low amount. Amount in these studies was prescribed as the amount of kcals of exercise energy expenditure relative to someone's body weight, so per kilogram of body weight per week. So both of these groups were performing 14 kkws, as I'll refer to them, per week. And while one group was working at a moderate intensity of exercise, and the other group was working at a vigorous intensity exercise. So you're holding the amount constant, so that way you can identify any potential intensity effects on your outcomes. Then if you look on the right, here I've drawn two arrows between the third and fourth groups listed. So here, both groups were performing vigorous intensity exercise, and the amount of exercise was varied. So there was 14 kkws versus 23 kkws. And so brief highlights from the first STRIDE study. Overall, we observed beneficial effects of aerobic exercise on several cardiometabolic outcomes, including body weight and composition effects, insulin action and insulin sensitivity, metabolic syndrome criteria, and cardiorespiratory fitness. And we noticed or observed some strong dose-response relationships between the exercise amount and the health benefit, especially compared to inactive controls. And we also saw some interesting results related to the intensity of exercise. And so I'm going to walk through a couple of the main examples that we learned from STRIDE 1 here regarding dose-response effects. So here on these figures, if you look along the bottom row, the inactive control group is on the far left here, and the exercise training groups are ordered here. The second bars are the low amount moderate intensity group, followed by low amount vigorous, and then high amount vigorous. So here, one of the dose response effects that we noticed was in relation to change in SI, which is insulin sensitivity, determined from an intravenous glucose tolerance test. This is largely a marker of our peripheral insulin sensitivity. And we also looked at changes in plasma triglycerides. And these are stacked on top of each other because we saw the same pattern here. And let me illustrate that a little bit further. So first, I'm going to draw your attention to the two middle bars here where it shows the intensity effect. So these are same amount, low amount, and then we're looking at the effects of moderate intensity compared to vigorous intensity. And here, what we observed was that when holding that amount constant, it was actually a little bit paradoxical and unexpected, where moderate intensity exercise was more beneficial for some metabolic outcomes compared to vigorous intensity exercise. And then on the right two bars, to discern an amount effect, another surprising finding here was that if you're doing vigorous intensity, you actually had to do almost double the amount of it in order to achieve the same type of health benefit as a low amount moderate intensity group was. And you can think about the low amount moderate intensity exercise akin to brisk walking, essentially. And so this really kind of went against traditional wisdom at the time in exercise physiology research, where and in the fitness world, where it used to be, like more amount is always better and higher intensity is always better. And so here, as I mentioned, that low amount moderate intensity group was actually outperforming the others when it came to certain metabolic outcomes. On the other hand, if we look at changes in cardiorespiratory fitness, which we assess in the STRIDE studies as peak VO2, or the peak oxygen consumption as assessed during a graded maximal exercise treadmill test, when we look at the groups here, we see more of that standard conventional dose response effect of exercise, where the inactive control group did not see any change over their 6-month inactive period. The low amount moderate intensity exercise, after 8 to 9 months of training, they significantly improved their cardiorespiratory fitness. You do a higher intensity of that same amount, you get even better improvement. And then the group that performed the best was that group that did the highest amount of vigorous intensity exercise. And so to date, what I've been showing you are mean bar graphs and looking at the standard error of the mean. That's typically what we look at when we're analyzing results from, say, clinical trial. But what I want to now draw your attention to is the variability around these mean group responses. So here, I've taken those exact same participants that created those mean bar graphs and created waterfall plots representing here, each bar is an individual's change score during the STRIDE study. I will draw your attention that here I do not have these magnitudes of individual responses plotted at the same Y scale level. So here this represents a 25% change, 40%, and so on up to an 80% scale in the bottom right graph. So as expected, what we expect from any normal distribution or a Gaussian curve is that we'll have a mean and then people will fall on both sides of that. So we expect some variability. But what we start to see here is in the inactive control group, on average, most people are either staying the same or potentially declining in their fitness over time. You do a low amount of moderate intensity exercise. Here we start to see a shift in the number of individuals that are increasing their cardiorespiratory fitness. You increase the intensity, more participants are seeing a positive beneficial response in fitness. And finally, here's that high amount vigorous group, where essentially everybody looks like they're, almost everybody is improving their level of cardiorespiratory fitness. But one of the things that I'm really interested in is, even though we expect this individual variability of response, wouldn't it be nice to know if you were going to be one of the people that were going to fall in these red circles here, which outlines people that essentially had either no response or in some cases a negative response to training in an outcome of interest. And so that's one of my areas of research I'm really interested in starting to understand. Can we identify individuals at baseline who are more or less likely to respond beneficially for their outcome or health clinical need of interest to a certain exercise dose? So one of the questions that we have in assessing this individual variability is looking at, okay, so maybe somebody did not have the average expected improvement in their cardiorespiratory fitness levels. Does that also mean that they're going to have no beneficial response in other important outcomes of interest? So to illustrate this, what we did was we took some individuals from the first two STRIDE studies, and each line or row here represents an individual participant's data. And we took those that had the greatest negative or null change in their percent peak VO2 following the intervention. With someone in the top row here, they actually lost 37% on average, even though they were in a vigorous intensity training group. And then we go across and we look and see here in these outcomes that are related to essentially metabolic syndrome, they did not necessarily have a negative response in all of these other important health outcomes. So here, red squares denote a negative response outside of the technical variability of the test, and a green represents a beneficial response. So again, all of these people here that are plotted out essentially had no change or a negative change in peak VO2. However, that did not mean that they were necessarily a low or a non-responder in these other really important health outcomes of interest. And in fact, as part of my doctoral dissertation work, I was looking at this type of data across 8 large exercise clinical trials that were done across the nation. And when we looked at these changes in these essentially the same outcomes here, we only found that about 1% of over 1,000 participants was considered to have no or a non-response in all the important clinical health outcomes that we were assessing. So just because you're a non-responder in one outcome does not necessarily mean that you're going to have a null response in other really important health outcomes. And so part of my work now is working to try to, like I said, can we identify patient characteristics for somebody at baseline, and depending on what their clinical need is, better prescribe or tailor them to an exercise program that's going to be more likely to give them a beneficial response in what they need to improve. And so this work truly is kind of still in its infancy. for what we call precision exercise medicine, but that's the direction that we're embarking on now, especially now we're involving some of our bioinformatics colleagues to allow us a new way to look at causal and predictive modeling to better understand what's happening with our exercise training responses at the individual level. So one other question that we had in relation to these variabilities of response is wondering, well, what about low training adherence to the program? Could that potentially be what's driving these low responses? But the answer is not necessarily. So from some of those same participants that we were looking at in the previous figure, here we plotted out, for example, these are individuals that had a positive change in their peak VO2. On the right, individuals that had a negative change in peak VO2. And below that, these are the same individuals' magnitudes of their adherence to the training program. So you can see that even for those that had greater adherence, especially over here, that didn't necessarily translate to a positive outcome in their change in percent peak VO2. So lots more work to understand here. So next I'm going to transition into looking at, well, we know at least on the group level, group averages, how beneficial exercise training can be, especially for cardiometabolic outcomes and peak VO2. But what if exercise training can potentially lead to some sustained health benefits? And so, especially in relation to here, we're part of the Pepper Centers, and so we're really interested in aging and how do we score off the morbidity and mortality curves to improve how we're aging. And so we are all well aware that improvements in life expectancy have led to a growing aging population. And even though we're living longer, older adults are faced with an increased risk for chronic diseases and physical disability, among other things. So as we just talked about, exercise training is pretty well known to elicit some substantial health benefits, yet too few individuals actually adopt an exercise program as a health maintenance strategy. And too often, even middle-aged adults, they might adopt an exercise program for some period of time, and then later they abandon it altogether. So even for those that adopt an exercise program, even if it's for a relatively short period of time, such as those individuals in the STRIDE study, 6 to 8 months of exercise training, do any of those short-term exercise-induced health benefits potentially last over time? And so what we call these sustained health benefits are legacy health effects. So we define that as the sustained benefit of a treatment long after cessation of that treatment or intervention. And the concept of legacy effects were first adopted in medical literature in 2008, where there were some studies that documented benefits of early and strict control of diabetes on cardiovascular complications in the UK prospective diabetes study. And even though they stopped that treatment, they followed these participants up 10 to 20 years later, and we're still seeing some lasting health benefits. And so there have been other glucose pharmacologic studies. There have also been some pharmacologic lipid studies with intense statin control, for example, that have documented long-term sustained legacy effects from these previous treatments. And then we also started to see, for example, with the Diabetes Prevention Program's outcomes study, longitudinal follow-up of these participants are starting to document some long-term health benefits from combined lifestyle interventions. So that was really the idea behind us being like, okay, well, what about structured exercise training programs? Are those also able to elicit some of these legacy health effects? So that gave the idea for us to invite back approximately 10 years after they were with us for their original STRIDE intervention study to come back and return for what we lovingly call our STRIDE reunion study. And these studies were essentially just a longitudinal observational study where participants came back in and we took fasted blood samples from them. We also measured their blood pressure minimal waist circumference, and they performed a maximal cardiopulmonary exercise test. And so as we've noted here, there were 104 of our Stride 1 participants that were excited and very enthusiastic to come back and return for a reunion study. So what did we find? So here, I have set up the bar graphs the same as what I started the presentation with, where the inactive control group is shown as the far left bar, followed by the low amount moderate intensity group, the low amount vigorous intensity group, and then the high amount vigorous intensity group on the right. These change scores in all the panels that I'm about to show you, those represent the 10-year reunion value minus the baseline or pre-intervention value. So this also includes that period of time where they potentially had a training effect and then the ensuing 10 years later. So what did we find? So first, I've been talking a lot about peak cardiorespiratory fitness, so we'll start there. On the far left, I'm going to draw your attention to the inactive control group and the low amount moderate intensity group. Here, these two groups averaged a decline over that essentially kind of like a 10.5 year period of about 10 to 11%. Now, this is essentially what we expect based on cross-sectional data. We expect that as we age, people lose on average about 1% of their peak fitness per year. So 10 years later, saw an expected 10 to 11% decline. However, with the two groups on the right here, these two groups were the ones that performed vigorous intensity exercise. And here, those two groups only saw about half that amount of decline over time. So this was really exciting to us that something about that vigorous intensity exercise is potentially protecting them from that expected attenuation over time. Next, we looked at changes in mean arterial blood pressure. And here we start to see a pattern that mimicked some of the original results from the study. I know I didn't previously show you blood pressure, but here we actually saw where the low amount moderate intensity group had the largest reduction over time compared to the other three groups. And this effect remained even after we controlled for participants that were now currently taking blood pressure medication. And looking at one of our metabolic outcomes, in the bottom left corner, we have changes in fasting insulin shown here. And again, here, that low amount moderate intensity group has the best persistent health effect on their fasting insulin levels. And then finally, on the bottom right here, I'm showing changes in minimal waist circumference. So here, the inactive control group experienced an increase in their waist circumference over time. However, participation in any of the three exercise training groups mitigated any change, and they were actually essentially looking like they had the same exact minimal waist circumference as compared to before they even started the study. So these findings were extremely exciting to us. This was just a small study to start to investigate if exercise even can potentially elicit legacy health effects. And so it turns out it can. And some of these exercise effects are dose response specific, even in the long term. So as I've mentioned before, I'm also really interested in variability of response. And so we decided to look at changes in peak VO2 in another way. And so here, what we did is we took all the participants that were in one of the exercise groups. So control participants are excluded here. And what we did was we categorized all the exercise participants, regardless of their group, by how well they responded in peak VO2 in the short term. So these are tertiles of change for that 8 to 9 month exercise intervention. So those that had the lowest response are shown in red. Those that had a medium response are shown in blue, and then those that were in the highest response tertile are shown in green. So here, it's easy to see visually that high response group, they're really getting a great increase due to training in the short term. And then we follow everyone out to these points over here. These are their average values out at the reunion time point, 10.5 years later. And if you look at the rate of decline, it seems like the slopes are about the same. But what's different here is that those that got that big boost from training, you follow them out and their reunion value is essentially no different than when they were 10.5 years ago. So something about that greater short-term fitness response in this Stride 1 cohort is related to a better maintenance of their fitness over time. Compared to the other two groups, they end up significantly less than they were at baseline, the pre-intervention value. And so here, this is one of our nods to, it looks like we're able to bolster somebody's physical reserves so that later in life, they've actually maintained their fitness better. So we were highly encouraged from our results from the first STRIDE study that, as I mentioned, there are some potential legacy health effects related to strictly just exercise training. And so we ended up applying to NIH for funding to perform other legacy studies in some of our other STRIDE cohorts. And so we were thankfully funded by an R21 through the NIA to conduct a reunion study in our third cohort, which was STRIDE prediabetes. So in the original STRIDE prediabetes trial, we had 4 groups. There was not an active control group this time. However, we do have on the top here, this is the moderate intensity exercise plus diet group. That's the clinical lifestyle group that mimics the lifestyle arm of the diabetes prevention program. So they were performing moderate intensity exercise and at an amount of about 11 kcals per kilogram per week. Then we had 2 other moderate intensity groups at varying amounts and 1 vigorous intensity group. So here, these top 2 groups performed the same amount and intensity of exercise. The only difference was whether they had the diet component or not. So here we're looking at the effect of weight loss or not on this exercise dose. Then if you look at the 2 groups in the middle, here we've held the intensity constant, so both moderate intensity aerobic training and varied the amount here. And then finally, we have another a set of groups that allows us to look at an intensity effect of moderate versus vigorous at the same amount of 17.5 kkws. So at the time of the STRIDE reunion study for this third STRIDE cohort, this cohort came in on average about 12 years later, so a little bit longer follow-up time. And on average, our participants are about 70 to 72 years old. We had essentially the same proportion of women and white participants that came back that's comparable to the original study. With essentially an overweight to obese BMI. And here now, on average, their peak VO2 for this age group is in the low 20s in relative peak VO2 terms. What's interesting here in the STRIDE prediabetes group is that we were able to look at, since everyone was considered to have prediabetes at baseline, how many participants that came back for our reunion study actually converted to type 2 diabetes. And here we had 3 participants of 18 that came back from the high amount moderate group. The high amount vigorous group, 2 participants out of 20 currently have type 2 diabetes. Nobody from the low amount moderate intensity group that returned has diabetes. And then finally, in the diabetes prevention program like group that had exercise plus diet, 3 of the 17 participants returned and had type 2 diabetes. But overall, the rate of incidence here appears to be lower than that of what has been observed in the diabetes prevention program outcomes studies. So let's take a look at some of the same outcomes that we assessed in the STRIDE 1 reunion study. So on the next few slides, I've repositioned the same STRIDE 1 reunion figures that I showed you earlier on the left. as a point of comparison to the participants that came back in the STRIDE PD reunion study on the right. And so first here, it turns out that participation in any of the exercise or an exercise plus diet group still mitigated that potential increase in minimal waist circumference here. So any of the exercise doses appear to protect and maintain minimal waist circumference over time in the STRIDE prediabetes group, which was the same thing that we saw in the STRIDE 1 reunion group, compared to those inactive control participants that gained in waist circumference over time. Next, in looking at comparisons of changes in cardiorespiratory fitness, again, we have STRIDE 1 on the left, and over here are STRIDE PD participants on the right. And here's where some of the interesting findings in comparing these two cohorts start to reveal themselves. So here, it was interesting to us that we saw greater magnitudes of change in decrements of peak cardiorespiratory fitness over time. So here, the moderate intensity group, even though they performed a higher amount than what was done in STRIDE 1, they lost on average about 16% of their peak VO2 compared to the moderate intensity exercisers in STRIDE 1, averaging about 10% decline. And then similarly, when we look at the high amount vigorous group here, we did not see the same protective effect of vigorous intensity exercise as we did in STRIDE 1. So here, to make this comparison a little bit easier to see, these are essentially the same exercise prescriptions, but here in STRIDE prediabetes, those participants lost about twice that amount that our STRIDE 1 vigorous intensity exercisers were losing over time. So this really intrigued us, like I said. And so one of the things that we wanted to start doing was looking into, are there potential sex differences in what's happening in these long-term outcomes over time? Because even though I don't have time to show it today, a lot of our short-term responses are, they vary based on sex. And so here we're wondering, is that playing a role in differential effects in the long term? So here, this larger figure on the right shows the data from the left that are broken out by men in the blue bars and women in the red bars. And here, the striking difference we observed was that in that high amount vigorous intensity group here, the men were really kind of driving that larger mean change here, where men were losing on average about 16 to 17% of their peak VO2, whereas women that did the vigorous intensity group, they were maintaining better and they were closer to that expected decline that we saw from STRIDE 1. Thankfully, because we had funding from the NIA to perform this STRIDE PD reunion study, we were able to add in a couple other outcome measures. So we were able to assess body composition with BOD-POD, which is what was originally done to assess body composition in the original STRIDE study. So we have the same measurements to compare over time. So here, I'm going to illustrate some of the body composition changes by looking at changes in absolute fat mass over time. So here, I'm going to orient you. The figures are set up a little bit differently now. So here we're looking at these changes by men versus women. So women are in the red bars on the top, and men are shown in the blue bars on the bottom. And here the groups are set up from high amount moderate, high amount vigorous, low amount moderate, and low amount moderate plus diet. The bars here represent, these are the average changes for that sex and group, average values at baseline is the first bar, and then the immediate post-intervention is shown as the second bar. So I've put a red square around this low amount moderate plus diet group here because we expected that those in this group, because they were intentionally losing weight over time, we expected them to have the greatest change in fat mass over time. So that's exactly what happened here. Women and men on the bottom both significantly lost their fat mass from pre to post intervention. Then what happens when we look at the long-term follow-up data? So now I've added in the average values for men and women per group in these diagonal lined bars here. And so I'm going to keep your attention for now on that low amount moderate plus diet group. So as we expect from other weight loss studies, we expect to see a rebound in weight and fat mass, for example, after an intervention is stopped. And we do see that rebound effect here. The women, they still fare off on average better than when they originally enrolled in the study. So it seems to still have some sort of lasting beneficial effect, even though the fat mass was not as reduced as it was immediately following the intervention. However, if we look at the pattern in men, the men seemed to rebound fully all the way back to where they were at baseline in the original study. So that finding here with the sex specificity in changes in fat mass over time is really intriguing to us. And next, let's look at a couple of the exercise-only groups here. So now I've drawn boxes around both high amount groups, where moderate intensity of high amount is on the left, and these second rows here are representing the high amount of vigorous intensity exercise. So here, it appeared that we're seeing an amount effect for long-term beneficial changes in fat mass, where the women here in both high amount groups continued to lose in their fat mass over time to where they're still significantly better off than where they were at the very beginning of the study. However, we did not see this same amount effect in the men that came back for the reunion study. So here, the men, all three exercise-only groups, they're seeing that same rebound in fat mass that the kind of gold standard with the diet group saw. So something's going on there that we also want to start to dig into and figure out what potentially is driving these sex differences. So a quick interim summary from some of our reunion studies that we've completed thus far. We did observe in this STRIDE prediabetes group legacy effects for waist circumference, fat mass, and I didn't show it, but total body mass. But compared to STRIDE 1, we were not seeing the same pattern of legacy effects for cardiorespiratory fitness, for example. And so we're thinking this is potentially because of a couple of reasons here. So one, the STRIDE prediabetes cohort was recruited to be older at baseline. Follow-up period was about 1.5 years longer on average. And we also think this might be related to an aging-related skeletal muscle mass loss, potentially driving these decrements in peak VO2 over time. And also how there may be a more accelerated fitness decline once we hit a certain age later in life. And so we have ongoing analyses to identify legacy effects and other outcomes. We also have just gotten back data looking that's going to allow us to look at some different plasma biomarkers, such as plasma metabolomics. We're also going to be looking at potential epigenetic markers of sustained legacy effects of exercise. So more to come on this. I'm currently writing the main outcomes paper from STRIDE P diabetes. So looking forward to having that out for publication soon. So to move into the final area of my talk, I'm going to talk a little bit about my current Pepper Rec Scholar Award. So here, just a quick overview that exercise training responses in general are impacted by a broad range of factors. So these can be things like our individual characteristics, like sex and age and genetics, our fitness level, the type of training. I've shown you different dose response effects of exercise so far, and how those outcomes might vary based on the type of exercise program you're doing versus what outcome you're assessing. So to optimize exercise recommendations for health, we really need to better understand our drivers and modifiers of exercise training responses. And this is an especially important need for those that are in middle-aged and older adulthood. So leading into my current study, to our knowledge, within the same individual, no one has examined how aging and prior exercise training potentially impacts our relative magnitude of response in different health parameters. So bring in now my ongoing, what I've called STRIDE IV. This is a pilot study. The IV stands for either STRIDE 4 or STRIDE Individual Variability. So that's my fun fact for acronyms for the day. And this purpose of this study is to assess the effects of aging on markers of physical reserve and exercise-induced adaptations in resilience in older adults who completed a structured exercise program within the past 12 to 15 years. So this is focused on those stride prediabetes individuals that I was just highlighting results from. And so here, physical reserve is essentially defined as our baseline capacity to withstand a physical stressor. Whereas our resilience is more dynamic. That's our ability to resist decline or recover function after enduring a physical stressor. And so the study design of my Stride IV pilot study here is that we're taking individuals, as I mentioned, that completed that 6-month stride prediabetes intervention and inviting participants to come back and reallocating them to the exact same exercise prescription that they did when they were originally in the study. The difference is now that it's tailored to their current fitness level and current body weight, but it's that same relative exercise prescription. So for the pilot study, I'm focusing on the 3 groups that were exercise only. We're inviting them back to undergo the same 6-month exercise training intervention and looking at their what their outcomes are looking like at baseline compared to the previous baseline. We've added a 6-week interim assessment of our main outcomes, and then again, repeating assessments at 24 weeks. So the aims of my pilot study, number 1 is just determine feasibility of whether or not these participants can return to successfully complete the same relative exercise prescription as that initial training exposure, and identify whether or not the assessments that we've added in as markers of physical reserve and resilience are also feasible now to conduct. Aim 2 is assessing the effects of almost 15 years of aging on markers of physical reserve by comparing our participants' peak VO2 and 2-hour glucose concentration. Those are 2 main outcomes at baseline of this new, what we call the legacy pilot study arm, compared to their baseline values from the original Stride PD trial. And then finally, the resilience aim 3, is looking at how 15 years of aging can affect our resilience to an acute physiological stressor following exercise training. And so here, the acute physiologic stressors are the cardiopulmonary exercise test for the peak VO2 outcome, and the oral glucose tolerance test is considered an acute physiologic metabolic stressor here, and looking at their 2-hour glucose concentrations. So the study is officially underway. I'm very excited. We've targeted 6 participants to come in, targeting 1 man and 1 woman from each of those 3 exercise groups. We've consented 4 of 6 already. So participants are over here in the left hand working their way through screening and baseline visits. Cardiopulmonary exercise tests, as I mentioned, oral glucose tolerance tests, and we have several secondary outcomes, including functional capacity, strength, body composition with BOD-POD, etc. So as far as next steps on this portion, just excited to get the study underway. We expect our first participant to start exercise training in this last week of April. Anticipate our recruitment to end with the 6 next month in May, and then intervention and data collection completion by the end of this calendar year. And in the meantime, we're working on getting R01 funding to complete the larger Stride IV project, where the idea is to include more participants in this legacy cohort and compare what their responses are like to essentially the same like age-matched control participants that would come in and do the same exercise interventions, and look at the effects of what prior exercise training has compared to participants that did not previously undergo any type of exercise intervention in about the past 10 years. So I know I took you on a long journey of all of my interests in relation to exercise training and aging and cardiometabolic health. I'm extremely grateful for your time and attention today, and I look forward to talking to many of you and always excited to expand my network and see potential collaborations. So please reach out after this if you would like to connect. But thank you so much.
Thank you. Thank you so much, Dr. Ross. It was a great talk. So many exciting things and really interesting food for thought.
Thank
We
you.
do have a bunch of questions in the chat, it looks like.
Okay.
The first question is, are any of the legacy effects related to some of the groups or individuals continuing to exercise or diet on their own?
Yeah, so I do get this question a lot. It's, what have people been doing in these intervening 10 years? The basic answer is we don't exactly know. It's hard to ask somebody, what have you been doing for the past 10 years in relation to your lifestyle habits? So not sure. We do ask several questionnaires. I wasn't able to highlight that in the time today. But we do look at self-reported physical activity in the previous 3 months. In stride one, that those that reported greater physical activity participation around the time of the reunion, no matter the group, that was associated with better outcomes. So now we've added in accelerometry data that we need to process, but in Stride PD to get a look at not only the subjective questionnaire data, but also an objective look at their current physical activity habits to look like there. We also ask a couple of questions if they've intentionally lost weight recently or have gone on a special diet, but we haven't had a chance to analyze that data just yet. We had just completed this study and are starting on analyses for the main outcomes. So I'm really excited to also dig in and try to understand as best as we can what potentially is driving these changes.
Second question is, have you looked at any association between physical resilience and psychological resilience?
I have not, but that's definitely of great interest.
And any association between doing sports in youth and exercise response in middle to older age?
I'm trying to think if I've seen any studies on that. I feel like a couple of years ago, I might have seen something in relation to long-term fitness outcome or long-term fitness in relation to youth sports participation. I have not looked into that as far as our stride specific cohorts though, but based on some of the findings that we're seeing with long-lasting effects, in my opinion, I would think that some of that would kind of be like a primer to help with our health in the long term.
And do you plan to study how exercise prescriptions benefit people who do not have a BMI that classifies them as overweight or obese?
Yes, I would absolutely look at that. Here, the STRIDE studies were intentionally designed to look at people that had essentially metabolic syndrome and overweight or obesity. So that's just the people that we've had available to invite back for reunion studies. But we are planning other grant submissions to perform these kind of long-term observational studies of other clinical exercise trial participants with greater ranges in age that they did the exercise training interventions and also a greater range of BMIs. So that's definitely on our radar.
Let's see, other questions from the group? Don't hesitate to put your question in the chat. These are great. Well, I guess that is all the questions, but thank you so much. This is really, really fascinating, and we can't
Thank you.
wait to hear the results from the next cohort, or next reunion, as you
Oh,
say. But we really appreciate you joining us today, and thank you everyone for joining our April Pepper round. We look forward to seeing you next month.
yeah, thank you so much. And I'm happy for Eleanor or whoever to share my email if someone wants to reach out and connect later. I would absolutely love to do so. But thank you all. Great questions.
Thank you.
Thanks.